Here we will discuss factors affecting hypoxic pulmonary vasoconstriction. The first among them is age. Compared with adults, HPV is more intense in the fetal and neonatal circulation. Second is the effect of carbon dioxide and pH on HPV. Now, both respiratory and metabolic acidosis cause pulmonary vasoconstriction, meaning both respiratory and metabolic acidosis augments HPV. Even a modest degree of hypercapnia in humans, say the partial pressure of carbon dioxide of 52 mm of mercury, leads to significantly increased PVR, that is pulmonary vascular resistance. Now, the normal PCO2 level is from 35 to 45 mm of mercury. In our example, the PCO2 is just 52, a raise of 7 mm of mercury. However, the response to hypercapnia is slow, having not reached a plateau after 4 hours. And on the other hand, both respiratory and metabolic alkalosis lead to pulmonary vasodilation, meaning they attenuate the effect of HPV. Now, this attenuation of hypoxic pulmonary vasoconstriction by alkalosis is a more consistent finding than the effect of acidosis. Now, the third factor affecting HPV is temperature. HPV is attenuated by hypothermia and enhanced by hyperthermia. So, in clinical settings where we want HPV to be effective, then we should not keep the patient hypothermic and try to keep the patient euthermic. The fourth factor is iron. Now, iron attenuates hypoxic pulmonary vasoconstriction and also greatly reduces the enhanced response normally seen after prolonged hypoxic exposure. So, iron supplementation has been suggested as a possible therapy for patients in intensive care who have a life-threatening combination of hypoxemia and pulmonary hypertension. Now, the next factor affecting HPV are catecholamines. Pulmonary vessels contain alpha-1 and beta-2 adrenoreceptors as well as dopaminergic receptors. Now, adrenaline, dopamine, dobutamine, dopexamine, and isoprenaline attenuate HPV. However, at high doses, these drugs cause pulmonary vasoconstriction in normoxic lung regions. So, at lower doses, vasodilatory stimulation of beta-2 receptors, which might attenuate HPV, is balanced by the vasoconstrictor effect of alpha-1 stimulation, until at higher doses, alpha-1 stimulation predominates and vasoconstriction occurs. The use of alpha-1 agonists such as norepinephrine or phenylephrine, both of which cause pulmonary vasoconstriction, is a more effective way of enhancing HPV. But it must be remembered that these drugs are not specific for pulmonary vessels, being potent systemic vasoconstrictors, and so their ability to improve oxygenation in clinical situations is limited by their effects on the systemic vasculature. Next is Almitrine. Animal studies have shown that at low doses, Almitrine enhances HPV by a vasoconstrictor effect specific to pulmonary arteries. Its mechanism of action remains unknown, although the effect is inhibited by nifedipine, suggesting a calcium-mediated action. When administered systemically, it has been shown to improve PaO2 during OLV, but it is not used clinically due to problems with correct dose selection. At higher doses, Almitrine vasoconstricts normoxic lung, which is problematic during OLV. And again, with chronic use, Almitrine has been associated with peripheral neuropathy. So it has been removed from the market in many countries. Next comes acetazolamide. Animal studies have demonstrated that at high doses, acetazolamide impairs hypoxic pulmonary vasoconstriction. At clinically used doses in humans, acetazolamide does not reduce pulmonary artery pressure. Another factor is inhaled nitric oxide. Nitric oxide attenuates HPV by causing localized pulmonary vasodilation. And by administering nitric oxide via inhalation, VQ relations, that is, the ventilation perfusion relations, may be improved. By this route, nitric oxide is only delivered to lung regions with some ventilation, and perfusion of these regions will therefore be enhanced. This is in effect providing a complementary strategy to that of hypoxic pulmonary vasoconstriction, that is, normoxic pulmonary vasodilation. In some patients with severe acute lung injury, nitric oxide inhalation alone or in combination with systemic vasoconstriction using phenylephrine may improve oxygenation by either improving VQ matching or by increasing cardiac output. However, during one lung ventilation, administration of nitric oxide to the ventilated lung has generally been shown to be of no benefit in improving PaO2. This is probably because the ventilated lung is almost maximally vasodilated when using an inspired oxygen fraction of 1.0. However, some patients, particularly those with pulmonary hypertension, may show an increase in PaO2 with inhaled nitric oxide during one lung ventilation. Now, high altitude pulmonary edema susceptible subjects have a significantly reduced HPV response at altitude after taking 8 mg of dexamethasone twice daily before ascent. The next factor is oral sildenafil, which almost abolishes the HPV response in healthy volunteers breathing 11% oxygen. Nitric oxide donors such as sodium nitroprusside and nitroglycerin attenuated HPV. Sublingual nitroglycerin causes a small degree of hypoxemia, and prostacyclin has potent pulmonary vasodilator properties, meaning it will attenuate HPV. Intravenous prostacyclin is useful for treating pulmonary hypertension in critically ill patients, but its effects on the systemic circulation cause significant adverse effects. However, when delivered by inhalation, very little prostacyclin is metabolized by the lung, so systemic absorption still occurs, but the dose by inhalation is small, so systemic side effects are reduced. And in animal studies, there is a dose-dependent reduction in HPV by verapamil and nifedipine, and similar findings have been reported with nifedipine in humans with COPD. Now, healthy subjects taking either ACE inhibitors or angiotensin II receptor blockers have significantly reduced HPV. So, in any clinical situation where HPV is desirable or when a patient is undergoing one lung ventilation, we have to carefully choose our drugs and medications, or we need to review the present medications of the patient and modify accordingly.
Say what you wanna say to me now. I wanna the morning. Say what you wanna say to